Med history.
Acromegaly is a pathological enlargement of certain parts of the body associated with increased production of somatotropic hormone, growth hormone, by the anterior pituitary gland as a result of its tumor lesion. It occurs in adults and is manifested by enlargement of facial features, nose, ears, lips, lower jaw, enlarged feet and hands, constant headaches and joint pain, impaired sexual and reproductive functions in men and women. It is diagnosed according to hormonal tests, X-ray of the skull, MRI of the brain. Treatment is carried out by medication, radiation, and surgical methods. Acromegaly affects about 50 people per 1 million population. The disease is equally common among both sexes, most often manifests itself at the age of 40 to 50 years. Symptoms of acromegaly: changes in appearance, lips, ears, and nose increase, brow ridges and lower jaw protrude, macroglossia. The tongue increases and thickens, which is why toothprints can be seen on its back. Thickening and roughness of the skin, severe sweating, irregular menstrual cycle, decreased erection and libido, signs of compression of the pituitary gland of nearby structures, headache, loss of sense of smell, visual impairment, decreased intelligence, and personality changes. As a rule, patients do not attach importance to symptoms for years and turn to the doctor after noticing changes in appearance. They are especially visible when comparing old and new photos. Acromegaly begins to develop after the body stops growing. Gradually, over a long period, symptoms increase and changes in appearance occur. On average, acromegaly is diagnosed 7 years after the actual onset of the disease. The disease is equally common among women and men, mainly at the age of 40, 60 years. Acromegaly is a rare endocrine pathology and is observed in 40 people per 1 million population. Elevated levels of growth hormone in the blood cause early mortality from cancer, lung, and cardiovascular diseases. Causes of acromegaly: the secretion of somatotropic hormone, somatotropin, STH, is carried out by the pituitary gland. In childhood, somatotropic hormone controls the processes of formation of the musculoskeletal skeleton and linear growth, and in adults it controls carbohydrate, fat, and water salt metabolism. The secretion of growth hormone is regulated by the hypothalamus, which produces special neurosecretes. Somatoliberin stimulates the production of STH, and somatostatin inhibits the production of STH. Normally, the content of somatotropin in the blood fluctuates throughout the day, reaching its maximum in the early morning hours. In patients with acromegaly, there is not only an increase in the concentration of STH in the blood, but also a violation of the normal rhythm of its secretion. The cells of the anterior pituitary gland, for various reasons, do not obey the regulatory influence of the hypothalamus and begin to actively multiply. The proliferation of pituitary cells leads to the appearance of a benign glandular tumor, pituitary adenoma, which intensively produces somatotropin. The size of the adenoma can reach several centimeters and exceed the size of the gland itself, squeezing and destroying normal pituitary cells. In 45% of patients with acromegaly, pituitary tumors produce only somatotropin. In another 30%, they additionally produce prolactin. In the remaining 25%, in addition, they secrete luteinizing, follicle-stimulating, thyroid-stimulating hormones, A subunit. In 99%, it is the pituitary adenoma that causes acromegaly. The factors causing the development of pituitary adenoma are traumatic brain injuries, tumors of the hypothalamus, chronic inflammation of the sinuses, sinusitis. Heredity plays a certain role in the development of acromegaly, since the disease is more often observed in relatives. The pathogenesis of acromegaly. Normally, the pituitary gland produces growth hormone, or somatotropin, STH. This hormone affects growth zones, epiphyseal plates, areas of growing tissue, and tubular bones. As a result, the cartilage tissue is gradually replaced by bone, and the tubular bones are lengthened. If the hormone is excessively produced in childhood and adolescence, when the growth zones are open, that is, epiphyseal cartilage has not yet ossified, gigantism or pathological tallness develops. With gigantism, men's height exceeds 200 centimeters, and women's 190 centimeters. In adults, these areas are closed, so an increased level of somatotropin leads to acromegaly. A person no longer grows, only parts of the body increase: forehead, ears, nose, lips, hands, and feet. Growth hormone is excessively produced in tumors of the pituitary gland. In rare cases, with the development of neuroendocrine tumors in the lungs and pancreas. Hypothalamic tumors can also lead to acromegaly. They secrete releasing hormones that stimulate the pituitary gland. Most pituitary adenomas occur spontaneously, and hereditary predisposition is detected only in 5% of cases. Familial idiopathic pituitary adenomas in 15% of cases are associated with mutations in the AIP gene. The causes of the remaining 85% are unknown. Excess growth hormone leads to the following changes. Carbohydrate metabolism is disrupted, and hyperglycemia develops, excess glucose in the blood. The mammary glands are stimulated. A whitish liquid is released from the nipples. Protein synthesis increases, which increases the number and size of cartilage cells, which eventually leads to an increase in body parts. The transport of amino acids into muscle cells increases. The internal organs work more actively and become larger. Complications. The course of acromegaly is accompanied by the development of complications from almost all organs. Heart hypertrophy, myocardiodystrophy, arterial hypertension, and heart failure are most common in patients with acromegaly. More than a third of patients develop diabetes mellitus, liver dystrophy, and pulmonary emphysema are observed. Hyperproduction of growth factors in acromegaly leads to the development of tumors of various organs, both benign and malignant. Acromegaly is often accompanied by diffuse or nodular goiter, fibrocystic mastopathy, adenomatous adrenal hyperplasia, polycystic ovaries, uterine fibroids, intestinal polyposis. Developing pituitary insufficiency, panhypopituitarism, is caused by compression and destruction of the pituitary gland tumor. Laboratory and instrumental methods are used to diagnose acromegaly. Laboratory diagnostics. An IGF-1 blood test, insulin-like growth factor, 1, is the optimal method for suspected acromegaly. The test is performed in the morning on an empty stomach. With the disease, the level of IGF-1 is increased, but it can also increase in women during pregnancy. In addition, an erroneous result is possible in acute inflammatory diseases, diabetes mellitus, nutritional deficiencies, kidney and liver failure, severe infections, sepsis, AIDS, burns, abdominal surgery, and oral estrogen intake. Oral glucose tolerance test, OGTT. The level of growth hormone is determined before the test begins, then 75 g of glucose is taken and measured again 2 hours later. Normally it decreases, but with acromegaly, it does not fall below 1 mg/L. This analysis also allows you to evaluate the effectiveness of treatment. The study of the basal level of growth hormone is carried out in the morning on an empty stomach 3 times with an interval of 20 minutes, after which the blood samples are mixed. This algorithm avoids diagnostic errors, prognosis, and prevention. The lack of treatment for acromegaly leads to disability of patients of active and working age, increases the risk of premature mortality. With acromegaly, life expectancy is shortened. 90% of patients do not live to be 60 years old. Death usually occurs as a result of cardiovascular diseases. The results of surgical treatment of acromegaly are better with small adenomas. With large tumors of the pituitary gland, the frequency of their recurrence increases sharply. To prevent acromegaly, head injuries should be avoided, and chronic foci of nasopharyngeal infection should be sanitized. Early detection of acromegaly and normalization of growth hormone levels will help to avoid complications and cause persistent remission of the disease.